Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
Good Wednesday afternoon. Thank you so much for joining us for this live webinar to discuss telehealth's role in helping manage patient care in the wake of the outbreak of the coronavirus or COVID-19. We're glad that you took time away from your busy schedules today to join us. My name is Laura Barnett, and I'm on the marketing team at Axxess. Before we get started, I'd like to tell you a little bit about Axxess. We're a leading home healthcare technology company offering a complete suite of easy-to-use, innovative software solutions, empowering home health, home care, and hospice providers to grow their business while making lives better. Today, you'll hear from my friend and colleague, Arlene Maxim. She's a clinical consultant at Axxess. She has several decades of experience in home health care and is a known and well-regarded thought leader in this area, so we're delighted that she's presenting with us today. Joining her is Neil Tantinko, another friend of mine, who is the CEO of Connected Home Living. We're delighted that both of them have carved time out of their schedules, just like you have, to share some information. Before we get started into the content, I want to share a couple of housekeeping items with you. Everyone's phones are currently muted. However, you may submit questions throughout the webinar, and if time permits at the end, Arlene and Neil will then answer as many questions as possible. If we don't have time to answer your questions, we will follow up with you after the webinar. So rest assured, if we don't get to you right now, we will get to you later. Following the webinar today, we will provide everyone with a link to the slides and also post a video recording of the webinar on our website at axxess.com. So before we spend more time on that, Arlene and Neil, thank you so much for joining us, and I'll hand this over to you.
Thank you, Laura. And we're equally as delighted to be here. And unfortunately, I don't necessarily like the circumstances, but we're here to provide education and help those who are having a difficult time understanding what's actually going on out there in the world of telehealth as it relates to the coronavirus. Yesterday, the CMS and Administrator Verma announced that they would begin using telehealth using a waiver. And that it's a little confusing right now. The only thing I had an email from Bill Dombey within the last couple hours, and the only thing that we see that we've received any relief regarding that announcement has to do with face-to-face. And according to the language in the waiver, it looks as though face-to-face with the physicians and admitting patients would be covered using telehealth. But that's the only thing right now that we have information on. Bill Dombey has told me that he and others working with CMS are using telehealth as one of the priorities for home health and hospice. So stay tuned for all the information. Watch the NAHC website, your state organization websites for the latest information on that. But on March 11th, as we all know, the World Health Organization declared the coronavirus a pandemic. That does not mean that we need to panic right now. We are in a fight to get this coronavirus under some kind of a control, but that announcement declaring the coronavirus a pandemic was just a cause for us to take action and pay attention to what's going on, particularly with telehealth. Neil's going to talk a little bit about connected home living, but this is a time where you need to start doing your research, get educated about telehealth. We may only have a matter of days and maybe even hours. I was talking to Neil a few minutes ago, and it's interesting to know that we were having changes last week, like between hours, and now it seems like only minutes go by and there's another change. So make sure that you're staying on top of things by watching the NAHC website and your state organization websites. Right now, we don't have any effective therapeutics against the virus. However, you probably heard that in the last couple days, in one of the universities, they have started doing some vaccinations. So we should get information. I think that actually happened much more quickly than they thought it was going to. So we should be getting more information about the effectiveness of the vaccinations very soon. It's estimated that 60 to 70% of the world population could be infected if we don't control it. So part of the control, as you all know, is to avoid face-to-face contact with folks. The masks and some of the things people have panicked and gone out to purchase and use over and over again. I was in an airport just last week and I saw the same mask being used by a couple different people through several trips transferring planes, and they were using the same mask over and over again. And those things that is not going to help control this virus. So we need to make sure that we're doing whatever we can to protect the health of everybody that we're coming in contact with. Can I have the next slide, please? So NAHC has requested consideration, again, based on that announcement by the World Health Organization. Bill Dombey has gone to bat for us, and I know the Hospice Organization has also, working very closely with CMS to try to fight the things that they as far as NAHC is concerned, is for telehealth to count toward visits and not charging us for not meeting LUPA threshold. So hoping that telehealth will take the place of visits, and I guess the reimbursement should not be affected. That is not in effect yet. I do know that that's something that NAHC is working very hard on, and they're working very closely with CMS on this. So remote care monitoring to be reimbursed by Medicare and Medicaid, again, is on the top of their list. So as Neil goes through the way connected home living works, you'll see that that's an actual remote care monitoring system. So the patient is receiving a face-to-face visit every day. Another thing I just want to bring up here real quickly is pay attention to your patients too. I've done a couple webinars on the loneliness epidemic. This is not going to help that. And so some of your patients are going to be very, very isolated and very lonely. If we go with this 14-day quarantine with folks, there may be a couple weeks between individuals seeing another individual. So make sure that you're staying in contact with your patients, and even with phone calls. Again, telehealth is going to help that because particularly with remote care monitoring, we'll be able to do face-to-face communication with those patients. Next slide, please. So the telehealth can keep people healthy during the outbreak because we're not having that face-to-face contact. We're not touching things that are around the patients or the clinicians. That's another thing we have to be very careful about and be aware of, is that we have to protect our clinicians. Physicians, I've just read an article about 2 physicians actually having this coronavirus, and one of them, from what I understand, was critically ill. So we have a responsibility to not only protect patients, but also protect our caregivers. So again, the telehealth market is the perfect place for that because we are able to, again, do all of this remotely. Nurses would be able to actually work from home and visit their patients through their computers or through their cell phones. So the person-to-person spread would certainly be much, much less likely. So again, the healthcare workers are on the most danger. We're running out of protective gear. I just posted something on the site that Axxess has for coronavirus about some things that the CDC has come up with, some makeshift hand washing solution. So you might want to take a look at that. I would encourage you to look at Axxess's coronavirus folder, and we have an awful lot of information in there, but coming up with some protective gear is going to be a problem. Masks and gowns and gloves are on very, very short supply right now. So make sure that if you have the ability to get stocked up with those types of things without too much delay. There was an article that was published in the Journal of American Medicine in February, and it suggested the virus had 41% rate of transmission in hospitalized patients. So another thing we have to think about is making sure that these patients don't go in the hospital, don't go to clinics, don't go to the doctor's offices. But many of the hospitals, I think probably nationwide now, I know They were setting up in California, and we've had in Michigan, we've had a number of our hospitals setting up tents where patients who have some symptoms of the coronavirus are being triaged in these tents, and we don't want them going around people who were already sick, or many of these people that are ill in the hospital with other things, intensive care, perhaps because CHF or other things, are actually ending up getting the virus in some of the hospitals just because they're an actual patient. Next slide, please. So patients that are becoming ill at home and are self-quarantine will be able to use telehealth monitoring to actually have a visit with their nurse practitioner, physician assistant, or physician without going into these emergency room. And urgent care centers is another place to keep these people away from. They should be using the telephone or again, telehealth to stay away from these places that are crowded with people who are already ill from maybe even other things. So just make sure that you educate your patients to stay away from these clinics and these hospitals and doctors' offices and emergency rooms. Besides the fact that it's a huge strain on these doctors and nurses that are trying to triage these folks in these places. So it takes less than 5 minutes to set the telehealth up. Neil's going to go over that. In China, where this all started, telehealth is already on the rise. There's one telehealth company that reported they had 400,000 online inquiries in 4 weeks. So that's just unprecedented for just the telehealth business itself. The next slide we look at, and I would recommend that each one of you, if you don't have this already, you make a copy of this slide and put it up in your offices and hand it out to everybody that you can get their attention of. This talks about flattening the curve, and this is what we're attempting to do by using telehealth, by using other means to keep folks away from each other. You've already probably heard about the 6-foot rule, making sure that you're not in places that have more than 5 people in one place. In the grocery store, folks are touching everything in the grocery store, picking it up, looking at prices and that kind of thing. So make sure that you've got disinfecting solutions with you that you carry around in your purses and your pockets, and make sure that you clean your hands after touching anything. This virus is hanging around for several weeks in some cases, depending on the type of service. But what we're trying to do is do the intervention, get all of these things in place, keep folks away from one another, self-quarantine yourself if you feel like you're sick. With intervention, we're going to flatten that curve much more quickly. And that's one of the problems that China had, was that they did not take precautions. They didn't alert the folks that needed to be alerted. And so without the intervention, they had a significantly higher loss of life. The other thing to know that with China being the example, most of the folks that died in China were smokers, which I thought was very, very interesting. Even, I guess it's not surprising, but it was interesting. Most of them were men. In fact, I think the percentage was 80%. In the United States, however, they believe that the patients who will actually succumb to this virus will be obese folks who also smoke, or one or the other. So be aware that those folks, and you all know probably the age groups that are affected by this, so are adversely affected by this. So those folks need to have extra care. Neil, I'll go ahead and turn this over to you for the most interesting presentation on telehealth itself.
Okay. Well, thanks, Arlene. I appreciate you providing that input. And hello, everyone. It's a pleasure meeting you all. I may have met with you during the Axxess Roadshow. So I'm the founder of and CEO of Connected Home Living. All we do here is prevent readmissions, and now we have designed our solutions specifically to address the coronavirus pandemic. So folks, telehealth, you're seeing it all over the news, right? CDC is not just suggesting, now they're emphasizing the need for telehealth to curb the pandemic, right? So in addition to that, you saw the news maybe a week and a half ago. Congress passed the emergency coronavirus fund worth about $8.3 billion, and out of that $8.3 billion, $500 million is set aside specific to telehealth, and now we're about to get another supplemental that's going through Congress. They don't foresee it being blocked, and it'll be signed here very shortly. That's another supplement to, and a lot of it will be revolving around telehealth. And I also saw the news that FEMA is also going to be putting money into telehealth. So there's no bones about it, right? Telehealth is going to be here to stay. In addition to that, one of the major changes is that they've now lifted many of these restrictions, which will now allow physicians to get compensated on virtual visits. So before, physicians can reimburse for serving clients or patients that are in rural or underserved regions, and now those restrictions have been removed, and so now physicians can now render their virtual visits, provide the diagnosis, but also approve that those testings to be done through a secured video calling platform. All right. The other surprising news here that I just read a day and a half ago. This came from Johns Hopkins. They're predicting there's going to be a 9.6 million patients that are going to be hospitalized for the COVID-19, and about 3 million of those patients will require ICU care. Okay. The problem with that is that there's only 100,000 ICU beds across the United States. So majority of these patients are going to be treated at home. And when they go home, guess what? They will need a clinical counterpart like our friends here in this webinar. So the question is no longer why telehealth, right? The question now should be, holy smokes, what is the speed to deploy this? Because there's a lot of questions you should be asking if you are thinking about this now. So, right. So the number one question, holy smokes, I need to get my my telehealth up and running. But what technology should I utilize, right? There are so many to choose. I think there's over 200 remote patient monitoring systems out there. Are you going to take the time to look at each one, or at least 3 or 2 or 3 or 5? Now, once you choose your technology, you have to ask the question, okay, who's going to customize my telehealth system? These software vendors, they're going to give you the software, but that's pretty much it. They'll hand you the software or the technology, and you still have to customize your system. Right? They'll give you some templates, but for the most part, you have to do things on your own, right? Who will develop the workflow? Who will build the clinical pathways, right? Again, the templates will be provided, but the burden is going to be heavily weighted on your shoulders. Who's going to respond to the telehealth alerts? Will these be medical or non-medical folks? Are we going to be Monday through Friday, or is this going to be 365 days a year, 24/7, all right? Who will program each of these patients' telehealth? As you begin to receive these telehealth patients, each of those telehealth systems has to be programmed specific to each of those patients, based on their chronic condition, based on their personal vital parameters, special orders. Maybe there's new medication that they need to be, you need to track and so forth. That has to be programmed. The training of the patient, once you have it, you give it to the patient. What if they have a question about their telehealth? Who's going to troubleshoot if they're, let's say, using an iPhone versus an Android? And then lastly, obviously, we need to make sure the marketing team is fully equipped to know what to say and not to say, right? And how are we going to market this, right? We're going to build these collaterals from scratch. So again, these are things that you have to answer. But if you do decide to do this on your own, hopefully the epidemic will still be around, right? So let me show you more about connected home living, and I apologize for this being a commercial, but you can take this and you can just, if you choose not to embrace our approach, at least bring this up to the folks who you're going to be reaching out to if you are considering other solutions. So connected home living, all we do is prevent readmissions, and we've been doing this for several years, and our numbers are astonishing, right? Right now, our readmission rates are between 1.92 and 3.3, right? And so that is mind-blowing, considering if you go to a hospital and say, what is your current readmission rate for CHF? It's usually right around 17 to 22%. We can take that number and squash it down into single digits. And the reason being is because if you see this in this chart, right, the technology is definitely a key part, but we're going to make it easy for the home health agency because we're going to take that burden away from you. But the meat of our solution really is our workflow and protocol and that human connection. And I'll explain to you more about that. But we deliver this in a turnkey solution. So what that means is that we're going to provide both the technology and the human power, right? The people who are going to respond to those alerts. So that way you and your team can focus on more clinical and billable matters, all right? So I'll go more into details, all right? So the solution, maybe we'll start off with the technology because you're seeing it all over the map, right? So our solution comes in two form factors. They come on what we call an app. Sometimes we call it BYOD, which stands for Bring Your Own Device. What that means is that we're going to rely on either the patient or their family member or their authorized caregiver's personal device. So our app will run on a smartphone, a tablet, and even a personal computer, so long as it has internet, and preferably that has a camera built in, okay? It'll run both on Android and Apple. Now, for folks who don't have that device, we deploy what we call a telehealth kit, which you see there on the left side of the picture. So the telehealth kits comes with its own tablet, and it has its own built-in internet. And then we include these medical devices like a weight scale, pulse oximeter, and a blood pressure monitor. Right now, I hate to say it, but we are out of thermometers, right? And so, and right now we're actually waiting for more supplies to come in, but obviously with the advent of everything that's happening in the world, thermometers are a valuable commodity, right? So I'll go over more into details here. So, what we are being asked to do, because we have our solutions deployed now addressing many patients who have corona or potential corona symptoms, we're going to lean towards the BYOD, right? And so again, we're going to rely on either the patient's smartphone, tablet, or computer. And if they don't have one, we're going to see if we can get their family members or authorized caregivers to use their device, okay? Now, if we absolutely have to, we do have a finite number of managed kits or telehealth kits, which we can drop ship at the patient's home, right? And again, preferably, we're going to lean towards the app or BYOD and with the advent of everything that's happening around, okay? So I'll go more into details. The telehealth system has over 400 pre-built clinical pathways, so you don't have to build this from scratch. We've already fine-tuned this. We built what we call branch logic, and I'll explain more what that is. But the system's ready to get going, right? It has a dashboard. We have clinical charting. It has ability to track medication management. Obviously, virtual visits, that's built in, and I'll go more into details about that. And it's also integrated with other EMRs, especially with Axxess. Well, actually, right now we're working very diligently and working closely with the Axxess team. So we hope to have the full integration done here very shortly. But with or without the integration, the system is still very, very functional. Okay, I'll go more into details. Well, what's going to be most important, right, is every time a patient comes under our care, they're not just going to be receiving a telehealth platform that's ready to go, and it will be also personalized for each of the agency, but each patient will be assigned to a live 24/7 remote care coordinating team. And these care coordinating teams will be basically the same faces who will be conversing with each of these patients. We did this by design because we want the patient to feel comfortable about their interaction with their telehealth system. So if they're seeing the same faces over and over again, over time, they stop calling it telehealth. They're going to call it Maribel, Dora or Oscar, right? Because we're going to humanize that telehealth on your behalf. But these remote care coordinators, and I'll go more in greater detail, right? These are going to be their main function, right? Number one, they are going to program the telehealth on behalf of the home health, because we want to make sure that this thing's done right and done quickly. And also your nurses or your intake people are going to thank us that we're programming it on your behalf. But we're going to constantly monitor the results generated by the telehealth system. And we're going to be doing it 24/7, okay? But we're not just going to wait for these alerts. We are actually going to be proactive, reaching out to the patients, because sometimes some of these patients may not, in the beginning, they may not use and answer the questions given by the telehealth or the prompting of their vitals of the telehealth. So we're going to call them, especially for high risk, every day for the first 14 days, because we know based on studies, the highest probability of readmission happens during the first 10 days. Now, however, with this whole pandemic that's happening, we're going to take orders straight from our home health counterparts. So if we need to, we can call them multiple times during the day, okay? Number two, we're going to provide that timely intervention. Second, we see that alert, especially if it's a red alert, we're going to respond immediately. Now, we're not a 911, right? Where the second you pick up the phone, somebody's going to be there. Right now, our response time is anywhere from 7 to 9 minutes, because we could be on another line talking to a patient, to a doctor, to the home health, and obviously we can't hang up on them, right there and then. So we usually give ourselves anywhere from right around 9 minutes to response back, right? But when we do respond to the patient, we talk to them live on video, preferably. And we like videos because video calling, because number one, when you talk to the patients on the telephone, sometimes they do a fantastic job masking their ailments, and you don't want that, right? But when you see them on video, right, you can see if they're leaning forward and they're having a tough time breathing. You can tell that they have marks around their face. Maybe they've fallen multiple times. You can see that they're wearing the same muumuu for the past 3 days because they're afraid, maybe to go to the bathroom of falling. So anyway, video calling is very powerful. The other piece that we also leverage, that we have the ability to take secured photos, right? So maybe there's a wound that's going from stage 2 to stage 3 to cubitus ulcer, right? We need to see if the progress is getting better or worse, in taking pictures are valuable. The other piece too is that that's most important is that video calling component. We have the ability to invite multiple parties in the same video call. So this way, if we need to, we can invite obviously your nurse to join our call. We can invite the physician to provide their assessment, but we're going to be there to do that live on video. All right. I'm just going to go to not this whole entire slide, but I'll go over to the psychosocial needs, which Arlene mentioned earlier. Now that we have a number of patients on telehealth, my goodness, they are just yearning for social companionship, right? So the second our RCCs call into the tablet, they are, you can tell they've been yearning to talk to someone, right? And so that's the job of the remote care coordinators, to have that meaningful connection and make sure that they're reassured and not feeling lonely. But what we've done here at Connected Home Living is even greater, right? So we started a volunteer program. And so we have now several groups, and my favorite one is a company called Team Telehealth. Team Telehealth, basically it's a group of high school students that are college bound, and they're trying to fulfill the community hours. And so now we've recruited them and have them go through a what we call CHL University. And once they're HIPAA certified, we assign them to their respective patients. So now these high school students, and right now majority of them are not allowed to go to school. They're all, because all the schools here are now been shut down. Through their smartphone, they're reaching out to their patients, right? Just saying hello, providing them that reassurance, everything's okay. But also, if they do somehow, some way identify any disconcerting items, they let us know immediately, right? Anyway, that's part of our solution. Okay, So let me go through an actual use case, right? So you're probably curious, okay, all right, how are we as home health going to address this solution through telehealth, right? So probably the best way to describe it, we'll go through an actual use case. So right now we have dozens of home health agencies who utilize our technology today. And right this very minute, they are going after their existing client base, their existing patient base. They want them to, they want to enforce their emergency program, and they are now reaching out to them individually and making sure that they have the telehealth in place, right? So once they've what they're doing right now. The first phase is going after their highest risk patients. These are patients who are above 65, who have underlying chronic conditions like COPD, pneumonia, like what Arlene said, obesity. They're going after them first, right? So as soon as they have identified those patients, they then would send CHL a referral form. The referral form will have obviously all the patient data, but it'll also have their underlying chronic conditions. But in that form, it'll have the patient's phone number or email address, right? And again, if the patient doesn't have one, we can install it on their family member or their authorized caregivers, right? But anyway, once we receive that form, right, the assigned remote care coordinating team will program the telehealth, and I'll show you what it looks like. And then once it's programmed, they will notify the home health agency that the telehealth system is now ready to go. Okay, so once it's ready to go, let's say the patient has a smartphone, they will receive a text or an email inviting them to participate in the telehealth program. Okay, and then in there they'll press the participate button, and then once they press the participate button, they're going to have to validate who they are by typing in their birth date as an example, because we're HIPAA certified, we're HIPAA compliant. Okay, and then from there there'll be a consent form that they would have to agree, which we'll be able to track as obviously, right? So once they click on that button, automatically our system will install the software, our application, directly to their preferred device. So in this case, in this example, we're going to show, let's say it's a smartphone. So the patient doesn't have to worry about going to the Apple Store or Google Store. It just automatically installs it, so it makes it really, really simple. Okay. Now, once they install it, we're going to know right away that they're now live, right? And so this is the screen that you're seeing here, that the patient will see on their smartphone. It'll say, let's begin our session, okay? And once from there, it's going to explain real quickly the intent of the program. And this is all pre-built already. It's ready to go, right? And then also, we're going to arm the patient to the teeth, all the educational content they need, because we know knowledge is power, right? We're going to start flooding them with all data. These are all coming from CDC. And then also, give them some additional advice. All right. Then from there, by the way, this experience right now is our screening experience, because we have actually 3 modes. Right now, we're going to first screen the patient. All right. So we're going to ask them about simple things like fever, right? Dry cough, shortness of breath. So if they press any of those answers, it'll go to the next question. It'll then ask you some additional questions, such as, have you been in this countries or been around with people from these countries who just visited these places, right? And then once we, let's say if they press China, then an automatic prompt will then tell them the disconcerting things about people coming from that country, as an example. Okay, and then or if the answer is not any of those that you see on the screen, then they can freely type in those answers that they feel that would be important for us. Okay, so this is the screening piece that we're going to show to our clients. Here's some additional ones that the patient will go through. Right, so Again, it'll ask about, within the last 14 days, have you had any close contact with people from these places, or do you know anybody who has these conditions, right? Again, if they press any of those answers above, we've already pre-built the care plan to provide these prevention steps and continue to monitor the symptoms, right? Here's another one that's going to prompt them to get some more additional data about sores and chills and muscles and so forth. And again, it'll provide some advice based on their answers, right? So again, this is just our screening experience. But once we receive this data, right, this is all going to come to connected home living, right? If they say, yes, I have a sore throat, yes, I have a dry cough and a fever, then that's going to cause a red alert, obviously, right? So once we get that data, we're going to immediately then get them through the next experience, right? And the next screening experience. But however, if they answer the screening experience and there's no disconcerting items, we're going to send this exact same screening 3 to 5 days from now. Okay. Now, however, if they do show some signs of items, we're going to automatically kick in the next care plan or clinical pathways, and I'm going to show you what this is. Okay. So we're gonna do what we call the self-isolation risk assessment to really get down to the roots and kind of determine how serious this may be, right? So again, what we're gonna do now is we're gonna ask some of these underlying conditions, right? We're gonna ask if they have diabetes, we have any renal disease, and other items, because obviously these items are going to be deemed more disconcerting, right? So other questions we're going to ask is if they're pregnant, right? Do you currently smoke? Are you a healthcare worker? And the reason why we ask this is that if they are a healthcare worker, we want to know, who they touch, where they've been, so we can, if necessary, we need to, notify those other folks that they may have infected. Again, so these are some of the other questions. Have you had any contact with respiratory, did you have a contact with respiratory secretion or within 6 feet? And if they answered yes, right, another question will be prompted. But if no, they're done. So anyway, so the whole point of this second piece of this assessment is now we have all the information we need, because we're going to relay this back to the home health. And in the home health, what we recommend the home health do is to contact the physician. And they're going to call the physician and say, hey, doc, we have your patient under our current care right now, because they're under home health, before this outbreak really kicked in. And can you join our video call with the patient? And right now, you're going to get a 99.9% yes, right? And the doctor's going to be more than happy, number one, because they don't want this patient going back to the clinic or going to the ER. They are more than happy to get on a video call with your patient and provide their assessment, but more importantly, approve that coronavirus testing. Because right now you can't go to CVS or Walgreens and get a testing. You're going to need a physician's order. So once you get that order, right, now the patient or family can now get the patient tested and get that rendered immediately. Okay. Now, however, this patient is now going to be a person's under investigation. So now moving forward, we're going to do what we call self-isolation monitoring, right? So this is what it'll look like. So if they're a PUI, we are now going to ask them on a daily basis or sometimes twice a day more data collection, right? We're going to ask about their wheezing, their chills, their muscle pains, their dry cough, and so forth, right? Now we're going to force them to take their temperature. Now, hopefully they have their own thermometer, because right now we cannot supply any. But if they do take their temperature taking, right, let's say it's 100 degrees Fahrenheit, that will prompt an escalation, and that will show up on the remote care coordinator portal or on our system, saying, hey, this patient has a high temp, and we're then going to execute our predefined protocols, right? And then on the patient's end, right, again, we're going to emphasize, let's help everyone by preventing the spread. And again, there's going to be a bunch of recommendations that are going to be built in and other resources they can point out to, right? So we're going to constantly monitor these patients, and if necessary, right, based on our predefined protocols, we'll escalate matters to the home health. Home health then escalated matters to their physicians. Okay. So this is already done. This is already pre-built. And so the other things that you may want to know, and you may want to ask your other vendors, right? You want to make sure you have access to all this information. So here at CHL, all of your clinicians will have who are authorized to log into the portal. They'll be able to see their patients, and if you want, you can control the access. So let's say Nurse A will only have access to a certain patients versus Nurse B. So when they log into the portal, they'll only be able to see their own patients, right? So that's going to be done automatically. Okay. The other cool thing that we have the ability to do is that when the patient is using the BYOD, we can just text them directly to the app. It's a secured texting feature that we have. So maybe perhaps you don't have time to speak to them at length, and you just want to send them a quick hello. We can do that through the system. Okay, and then actually I'm going to skip through this because I want to make sure that we have some time for some Q&A. But here's the other key features, right? Again, we have the ability to send text messaging. We have already a library of resources coming from CDC that we can render on the smartphone, and also again we can render virtual visits, right? So if we need to get the physician on the call, it's really simple. So to get them on board. Okay. Here's one more view, and I'm going to shut up and I'm going to open up to the floor here. This is what if the patient has any questions, maybe perhaps they need to reach out to Connected Home Living. So on their screen, there's a little phone button on the upper left. You should see here. So when they press that, it'll prompt an alert to their assigned remote care coordinator. And then from there, the remote care coordinator will call the patient, and this is what it'll look like when it rings their phone, right? And so you just have to press that little green button to accept the call, and just like that, they'll be able to see their clinical counterpart, right? And if we have to, again, we can invite multiple parties to join our video call. So in that same video calling session, I can have the doctor, the nurse from the home health, and if need to, we can invite maybe the concerned family member. So all of us are in the same loop. Okay. So anyway, so again, the solution is here now. The reimbursement is constantly changing as we speak. Unfortunately, as we speak today, we're still working on with Bill Dombey and team of getting the reimbursement approved for the home health and hospice to be reimbursed. For me, I feel very bullish. I think it's going to happen, and it's going to happen soon. But then again, that's coming from a telehealth vendor. But we're confident that's going to happen. But you know what? I'm going to hush now because I want to make sure we have time for questions and answers. So Laura or Arlene, you want to open it up to the audience? Or
well, I had a couple more things that I just wanted to say. That to make sure, again, I just want to reiterate, we want to keep our patients at home, so we need to do everything we can to do that. Another point I want to make is to make sure that you keep your clinical staff safe and let them know you care about them. I've heard a number of stories. In fact, I heard just this week that there are a couple agencies that just closed their doors and told their staff not to see patients. And so that's going to cut out some financial resources that they had, but it also certainly is unsafe for the patients. And that's certainly not anything that's recommended at all to do. We have a responsibility. We can't abandon patients. We have a responsibility to stay in the homes as long as it's necessary and do the best we can in keeping ourselves safe. 60% of the hospitals right now in the United States have some sort of telehealth. The problem is the patients don't have the ability necessarily to connect with that telehealth, to telemedicine actually it is. So we have to try to do what we can to get these folks connected so that they can actually speak with their physician. You're going to see an improvement in patient outcomes as a result of telehealth. Most telehealth experiences show about 35% improvement in outcomes when they actually use telehealth the way it's supposed to be used. So again, try to stay safe, empower your staff, use the resources of telehealth or whatever else it is that you have that's going to keep these people out of the hospital, and make sure that you try to you can the risk of exposure of your clinicians. Laura, I think we've probably run out of time now. I want to go ahead and close things out. And as you mentioned earlier, Neil and I are happy to take any questions that anyone has. And I just want to thank Axxess. Even though I work with Axxess very closely, I'm one of their clinical consultants. The president of the company has just done an excellent job for seeing the need for resources that can assist in this during this crisis, and Axxess has just gone above and beyond any other software program that I know in educating not only us but also the agencies that we're working with and the community at large. So I would encourage everyone to go to the Axxess website and look at the resources that are available, and we can get through this. As John always says, we're all in this together, and we're going to get through it together. So Laura, it's all yours.
Thank you very much, Arlene. I appreciate that. Thank you for your wisdom and your insight today. And thank you, Neil, as well, for sharing your wisdom and insight and the information regarding telehealth. Obviously, this really is an evolving situation. So while this webinar was planned a little bit, this certainly was a very timely opportunity for us to share the benefits of telehealth. So we're delighted that you guys could carve out some time with us today, and certainly grateful to you, the audience, as well. We know that you have so many things on your plate right now and lots of plates to keep spinning. And so we appreciate the several hundred of you who joined us today. We're very grateful for your time as well. We will certainly provide everyone with a link to the slides. We'll also post a video recording of the webinar on our website at axxess.com. And I do encourage you to go there because we have built out a coronavirus or COVID-19 resource block of resources there on our website. So if you have additional questions regarding ways that you can help support your teams through this time, you can always go to our website, and that is constantly evolving, and we're updating that as we're able to share more information from the CDC and from the government and that sorts of thing, those sorts of things. You know, as we heard with the CMS administrator sharing news yesterday. So as things are evolving and coming to light, we're going to be your source of information for that. So we appreciate that you trust us for that. We're here to partner with you to make lives better. And we know that things are rough right now. So we greatly appreciate your trust. And we want to thank you as we have delivered, and we're constantly working to deliver on our mission to empower healthcare organizations and professionals with the world's best technology solutions. As Arlene said, stay safe, have a wonderful day, and please reach out if we can be of any more assistance to you. Have a good one.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on Software Advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.